Hello everyone, my name is Elizabeth Suka. I'm an editor at the Economist Intelligence Unit, Thought Leadership Practice. I would like to welcome you today to this webinar sponsored by Pfizer and Global Skin, entitled Policy Perspectives on Chronic Skin Diseases, Lessons for Atopic Dermatitis. This is a hugely important area, as skin diseases can often be overlooked by healthcare systems for their wider burden on families and patients themselves and their caregivers. Atopic dermatitis is also known as eczema. It's one of the most common skin diseases with a prevalence on the rise. You can participate in the debate by sending your questions using the link on your screen, and you can direct your question to a panelist or to the panel itself. This webinar is anchored in the findings of a new report that was published today by the Economist Intelligence Unit on atopic dermatitis, which looks at the impact of the disease and also analyses the policy response across 8 different countries. The report is available on the webinar website and also on the EIU Perspectives website. So this report finds that AD is this chronic relapsing skin disease that is often misunderstood and stigmatized, and it has extensive social and psychological impacts. Today we will understand more about the disease, explore strategies to address it. We will also look at the adoption of best practices, including integrated care, and the role of patient groups in supporting patients. I would like now to introduce our expert panel. We have Holly Shaw, a nurse advisor with the charity Allergy UK, which provides support and information to patients of atopic dermatitis and other allergies. Next to her is Christine Janus, the CEO of the International Alliance of Dermatology Patient Organizations, also known as Global Skin, and she can provide us that global perspective as her organization has over 90 members in 36 countries. We also have Dr. Paul Charlson, a general practitioner with a special interest in dermatology. And we also welcome Sylvie St. Laurent, a Senior Director in International Public Affairs at the pharmaceutical company Pfizer, where she interacts regularly with government officials. Thank you, everyone. So Christine, I thought we'd start with you. So what are the most prevalent skin diseases? I mean, the most prevalent skin diseases are dermatitis, psoriasis, acne. What are the most common themes emerging across these different skin diseases?
Well, I think one of the things that comes to mind immediately with the diseases you mentioned, and the very common ones, is that most of them are visible. Mm-hmm. And so the impact on people living with those diseases is often beyond the actual skin manifestation, is the stigma and the psychosocial impact.
And Paul, as a practicing physician, what are some of the main burdens that you see around skin diseases?
Oh, it is around symptoms. I mean, particularly with eczema, where you get a tremendous amount of itch, which affects sleep, work, concentration, everything. So the symptoms are key as well as the appearance.
Okay, thank you for that. So I'd like to move closer to atopic dermatitis now. So there seems to be a multitude of terms around the disease: atopic dermatitis, eczema, atopic eczema. Sylvie, is this lack of consistent terminology a problem for healthcare professionals, policymakers, and researchers?
It's a good question, and I think for everybody, in fact. And I just want to say that Pfizer is really proud to have partnered with Global Skin and the Economist Intelligence Unit to shed some light on some of the core issues for atopic dermatitis patients. But one of the things that we've come across is this multitude of terminology. And I think it has an impact on the understanding of treatment guidelines. It has an impact on physician knowledge. But I think what is most important is the impact that it may have on patient awareness and education. And so I know there's not a consensus right now, but I think it's worth asking the question, is there something that we can do to simplify this?
Very good points. Anyone else would like to add anything? Christine?
I would actually. We pulled a number of leaders from the atopic dermatitis, eczema community together, and asked them what would be the terminology that would resonate with patients, because I think that's where we need to look, to Sylvie's point. So and what came out of that was that we need to marry the two terms, and we have done that. So we're calling it atopic eczema, and we've actually just launched a website to bring that community together called Altogether Eczema rather.
exciting.
And
to
from
hear
a
that.
patient perspective, thinking about the way we communicate with our patients, Paul and I as clinicians, they understand the term eczema. So combining those two words is really important.
Yes.
So both clinicians and patients understand what it is we're talking about.
Right. Because a
Fantastic.
clinician may talk about atopic dermatitis amongst themselves. They may talk about that, and researchers might talk about that, but patients often in many countries will refer specifically to eczema.
So our report, found out it's just not an itchy scratch. It's there's a lot of quality of life issues. So Holly, what are the physical, emotional, and social factors associated with atopic dermatitis?
Well, the physical symptoms of atopic dermatitis can be extremely debilitating. So skin can be raw, it can be itchy, it can be cracked, it can weep, it can bleed. And all of those unpleasant physical symptoms below the surface of the skin can impact on quality of life and actually really impact on lifestyle and the kind of restrictions that patients have to adhere to. So that's things about the way they may wash, the kind of fabrics or things that they can have next to their skin, the types of foods they can eat, which can often trigger eczema flares. So it really does impact on daily life quite significantly for patients that can't just go out and do the kind of things that those that don't have a chronic skin disease can do.
And school and work life as well, it impacts on that?
Significantly, one of the key symptoms of atopic dermatitis is itch. It's interminable, it's very difficult to make that go away, and often that's prevalent during the evening when people are trying to get rest and their skin's trying to heal, and when it can't do that, people struggle to sleep, and then in the day it impacts on their working life, or if their children, impacts on their ability to concentrate at school, which can have knock-on effects on their ability to achieve good grades at school and things like that.
Would you like to add anything, Christine?
Sure. I think in addition to that, when we think about children at school or even adults in the workplace, there's the stigma. I'm going to keep coming back to this, I think. The fact that your skin looks raw and scary makes it hard for somebody to sit beside you, and children especially are very judgmental in a way, and will not want to be friends with someone who looks different, and I think our cultures they reinforce this. If we think about the bad guys in the movies and the films that we see, they tend to have skin issues. They tend to have bad skin, and so it's a common stigmatization. And with skin disease, this cuts across many of them. Skin diseases are both stigmatized and minimized at the same time.
Very good point.
So you have the stigma. I don't want you to come and sit in my pool. But at the same time, the same person might turn around and say, but it's just a skin disease. Get over it. It's not such a big deal. You're not going to die from it, right?
So Paul, AD can be seen as this cosmetic issue, not a chronic disease. So how is AD seen? Episodic or a chronic disease? Is there another chronic disease model that AD could learn from?
Well, I think there's lots of chronic diseases that are a problem in the same way, and I think, interestingly, asthma, which is in UK, is treated differently, really. There's a lot more resources been put into it, there's a lot more input. There's asthma clinics, there's asthma nurses in every general practice really now. And I think if you had something along those lines for atopic eczema, that would really make a dramatic difference to how it's managed. And actually it's not that difficult to do. And actually empowering patients to learn how to manage their disease just takes a little bit of time, and in educating them and getting more and more clinicians educated. And if you get that done, a lot of these people won't need to come to access any care, because they'll be able to manage most of it themselves.
Because our research, we found out that AD is mostly managed in primary care, and that our report found that there was limited training in dermatology. So for example, in UK medical schools, the students might have no more than 6 days in dermatology training. So some patients may be receiving suboptimal care. So what more can be done in primary care then, Paul? What can we do more?
Well, I think, as I just touched on, I think it's about, first of all, training clinicians to manage atopic dermatitis, eczema, better, and that really requires very little. It's really, the diagnosis is often very easy. It's the management, the time taken to teach them how to use emollients and how to apply emollients, because often the right emollients are prescribed, but they're not actually used properly. Because the classic use of an emollient is a little squirt, that's pretty much useless. You need to put it on thickly and allow it to soak into the skin, and that makes a dramatic difference. The other thing is, if you ask people how much emollient they use, they'll only use a tiny pot in a month when they're probably needing to use 5 big pots, 4 or 5 big pots. So the quantities that are prescribed are often too small, and that's about education of clinicians again. It's not necessarily a cost issue, it's more about education.
Thank you for that. I just wanted to know, is there a disconnect in terms of the management between what patients think is good management compared to what healthcare professionals think is good management? Holly, do you have any thoughts on this?
I do, and I think it links nicely back to what Paul is explaining about compliance and adherence with treatment. Quite often patients walk away from a visit to the GP or whoever's prescribing their treatments, and they have no real understanding of trigger avoidance for atopic dermatitis, of what may aggravate their eczema, what may make it worse, what are the right things to do, the wrong things to do. So there's a big part to play in patient education, to enable people to manage their skin condition. We've got to remember that there isn't currently a cure for atopic dermatitis. It's chronic, it relapses at different points. Whilst many children do grow out of it, over 50% do not, and it carries with them into their older and adult years. So getting it right early on is really important. We want to prevent eczema, atopic dermatitis becoming infected. We want to prevent admissions to emergency care facilities, because the economic burden as well, we have to consider that.
Is there a disconnect from your perspective, Christine?
Yeah, I think so. I think there's, what patients report is that it also takes time, and Paul's talked about emollients, but then there are other topical treatments that patients use, and if they're putting them on the specific areas where they have lesions, or they have their spots of eczema, that can take a lot of time, and you do that once or twice a day. That takes a lot of time, and after a while, I mean, it's fine in the first week or two, so adherence or compliance is quite high, but after a while the routine is quite burdensome, and children don't want to sit still that long, and adults have other things to do, and so and I think the other thing that patients report is that once their skin starts to look and feel better, they sometimes fall off because their skin's better now, and then it comes back. And so, so there's also a misunderstanding, to your point, about what optimal treatment looks like, and if patients understood, if they really understood, they need to keep it up, then they would probably do that. But it's a complex disease that has. I think the other disconnect is that it's more than skin deep, right?
Yes.
So there are other systems at play that aren't really being discussed. So there's a disconnect there.
Would you like to add anything?
Yeah, and that's what I think makes it interesting times, is that we're learning more about the disease, right? And the more we learn, the more this idea needs to be reinforced that it's just not just a skin rash. It's below the skin, it's inflammatory in nature, it's chronic, and that means a different approach. And to your point, patients need to understand that, physicians need to understand that, all stakeholders need to understand that. And so education is absolutely key. It's something that has to keep going, and you have to do every day and repeat. And I think patient groups are an excellent ally in this. Physicians can't do it all. We don't have enough specialists. And so I think everybody needs to come together and work in terms of just raising that educational awareness as a first step.
Thank you for that. So our report also found there was this incomplete data capture on the burden of the disease, and also this lack of consensus around the measures, around the severity scores, and also quality of life measures. So Christine and Paul, perhaps, so how difficult is it to make evidence-based decisions when there's this lack of consensus?
Do you want me to start?
Yeah, please do.
I think it's actually I think it's very difficult, and I think policymakers really struggle to come up with decisions when they don't have enough information about what the true impact is. And I know that in some HTA systems around the world, they are now coming to patient organizations and saying, can you tell us what it's really like from a patient perspective to live with this disease, atopic dermatitis or whatever the disease might be. And those patient organizations provide reports and provide information. The problem is that they don't have a lot of information. So actually what we're doing, our organization has, we have a project in the works called GRID, Global Research on the Impact of Dermatological Diseases, which will bring questions from a patient perspective and will provide that data that everyone can use to show what the true impact is of these diseases from a patient perspective.
Paul, would you like to add anything?
Yeah, I think this is all quite simple actually. In reality, it's just actually making it happen. First of all, you've got to decide what optimal treatment is, and I think there isn't absolute consensus, but we've got a fair idea what we need to do. So then it's getting that information out to the clinicians so they understand what optimal treatment looks like and what it should be. And then it's giving them enough time to explain it to patients and getting rid of the barriers around supplying the tools. So you have to explain to the patients what they need to do and then give them the tools to do it. And then it's also bringing the patient back and getting them to understand why they're not doing it. And often there's really good reasons why. So you have to ask people why they're not doing it, because they're embarrassed, you see. They won't tell you unless you ask quite often. And it'll be things like, smelly and horrible, I don't like the stuff I'm using, or I don't have time, or I didn't really understand what the doctor said, or I don't like steroids or something like that. So there's a scare for that. There's all my friends said if you use that, you know, that doesn't work, or you know, past experiences. And my experience is if you take the time and understand what you're doing and explain it to the patient and get their views, they can manage most of these. You don't need to make it complicated. You keep it simple. And I think that's the key thing.
So in our research, we noticed that countries use their own national guidelines. Sometimes they use guidelines borrowed from elsewhere or regional guidelines. I'm just curious, I mean, how useful are guidelines? I mean, do clinicians follow them, or are they using their own judgment, and how could policymakers improve them? Who would like to start us on this?
I can say that,
Paul?
I think the answer is we all absolutely follow every guideline and read every guideline. Well, of course we don't. I mean, there's so many guidelines out there. They're always changing, and people don't read them, and they don't keep up, and they forget. That's the first thing. And from time to time you go back to something and visit it and think, oh, I've learned that, and I've changed my practice. So I think they are useful in that it does give a guide to people to understand, but in real life I suspect that lots of people don't follow the guidelines for a whole host of reasons, and that does result in suboptimal care. And unfortunately there isn't the time to audit everything that we do all the time. But you've got to hope that people will gradually go in the right direction.
And I agree, and I think the work that we've done together here around the Economist report is one of those actions. You know, the more we can raise awareness and shed light on and increase the share of voice on this, because sometimes it's just we haven't talked about it enough. And now, as I said, the science is, the understanding of the science behind the disease is improving. We're getting more information on the systems, and so the more we come together and we talk about it, I think the more, you know, a physician is likely to say, oh, you know, that's something new for me, or a patient might say, oh, that's something new, or a policymaker say, well, maybe I do need to spend a little bit more time. So I think part of the challenge that we have is to shine a light on this and share and keep talking so that we have more robust conversations that are leading to actions and outcomes.
Yeah, and I'd like to add to that.
Please do.
I think what you said earlier is it's really simple. The concept is simple. I think the actioning of the concept is actually hugely difficult.
Yes.
And I think that's what policymakers and what medical systems grapple with all of the time.
Absolutely.
And I think this is where guidelines can and often, sometimes do play a role, in that guidelines, when you get a team of specialists who really understand the issues and understand the medicine get together and they put the guidelines together, those can be used by policymakers actually, and it can be used in their understanding of what optimal treatment looks like. And it may take 5-10 years before systemically it's all adopted, but if you don't have the guidelines there in the first place, then I don't know where you start.
Well, I think that's one thing, but there's also the economics of it, and I often think that the guidelines are set out by people, but the kind of economics behind it is often a bit sketchy, and it would be much nicer sometimes to have proper economic arguments as well as clinical arguments. I see that all the time. They come up with this wonderful idea and think that's fantastic, but you know, how much is it going to cost, and where's the money going to come from?
And those are relevant questions for everybody, I think. And you spoke a little bit about prevalence data and how this research has sort of uncovered the fact that we don't have good data on prevalence.
Not yet,
and what we do have is a little bit dated. And we also don't have good information or evidence or data around the cost of the disease. And so I think those are the first things that we need to be doing. And those are the things that will allow us to identify what are we spending our resources in the appropriate way.
Absolutely.
And so, you know, those are gaps, and that it's good to understand. And I think, you know, some of the first steps is, well, let's get some objective data out there so that we can take those steps that are going to change the landscape for patients.
Thank you for that. I'm just going to change topics slightly now. So accessing specialist care, dermatologist care. So it's a major issue we found in our report across the countries. So for example, there was a real density of dermatologists across countries. In the UK, 1 per 100,000 people. In other countries like Taiwan or Israel, 4 per 100,000 people. So there's a question to all of you. Are there enough dermatologists to meet the needs of patients of atopic dermatitis? And when are specialists involved in AD care? So who would like to start us? Holly, maybe. We haven't heard from you for a bit now.
Speaking on behalf of the patient organisation, I speak to many patients on a daily basis, and a lot of them have atopic dermatitis, and they often come to the helpline and they have questions over their management of their atopic dermatitis. They've been referred to a specialist, but they're often looking at several months down the line before they're getting that specialist input care. And there's a real disparity in the UK, as I'm sure there is in other countries, particularly regionally, as to accessing services. And it's how we can manage and safeguard those patients until they have access to that specialist care that's really important.
Yeah, but I think the role of a specialist often in this is often either diagnosis of difficult to diagnose areas of this, where there's crossovers, maybe it's a bit of psoriasis, you're not quite sure what's going on. Patients that are really difficult to manage, so the small percentage that actually you can't manage in primary care, which actually is quite a small percentage, the difficult ones. Those are quite small, and sometimes things like teledermatology can improve access. And I think also the culture in some countries is that the specialist then hangs on to the patient, when actually in reality you just need some specialist advice and input to everyone else, and then they can leave it and let everyone else get on with it. And I think sometimes it's a sort of pattern and practice that needs to change a bit.
And just touching back on education of primary health physicians, I believe that if education is improved at that level, and there's a greater confidence with managing mild to moderate atopic dermatitis in primary care, we won't see the need for patients to be referred. So
Absolutely.
I think that's a key thing as well.
I think I might bring forward a question from our audience out there. So one of the questions we have here is, what potential role do you see for digital health applications for consumers that help diagnose, classify skin diseases and advise on next steps or provide information? Who would like to start on that? Holly.
I think the way forward is using multiple channels of communication to educate patients, to help patients to track symptoms, to help with diagnosis. So I see that it's a really valid area of exploration.
Okay, Christine, would you like to add anything?
I think especially in harder to reach areas where everyone has a cell phone, but it's a 4-hour drive to see a doctor, let alone a dermatologist. That having the use of a tool, I think the concern might be that the tools are of high quality, and that people aren't being misdiagnosed. So potentially, you know, linking them through patient organizations or physician organizations where there's some medicine behind it, right?
Yeah, I think diagnosis of eczema is actually relatively easy in most cases. and there are a few cases where it's difficult, but most of the time it's quite obvious that's what it is. I think the issues come for me is around management and expert management, and I think, yeah, it's useful to have diagnostic tools and everything else, but in this particular condition I think a lot of it can easily be diagnosed. There are bits and pieces that are more complex, but it's actually a small percentage. It all falls down around the management and the use of the available tools that are out there, to my mind. Certainly in my experience it's all around the lack of ability to manage it by not using the right things appropriately. That's all. If you can do that, it will make a massive difference. So technology is helpful, more helpful in other conditions really. I think teledermatology is very useful in a lot of things.
And there are some countries that use
and it's
teledermatology.
really, really
That's very
useful,
helpful.
but not perhaps so much in this as other things actually, interestingly. But yeah, still helpful.
Did you want to add anything extra on the
No,
tele?
no, it's just agreeing.
Marvellous. So we'll move on to a slightly different topic now. So multidisciplinary care clinics, and these seem a good idea as AD patients have multifactorial needs, and so they could access psychologist, nurse, a dermatologist, a nutritionist, and this can give them the ability to better manage their disease. So in our research we found that multidisciplinary care recommendations were absent in AD guidelines used in the UK and South Africa, but present in the 6 other countries we looked at. So Holly, how can integrated care benefit patients with AD?
I think a multi-pronged approach to atopic dermatitis is key. We've discussed a variety of symptoms, from the debilitating physical symptoms to the psychosocial symptoms, and we have to look after patients holistically, so not just treating their skin. We have to think about their mental health and well-being. We've talked about low self-esteem, which can often lead to depression, and patients need the opportunity to be able to discuss how that disease burdens them. So being able to speak to a counsellor, having the ability to go and speak to a psychologist, having a nurse available to do education, having a clinician available to guide a patient through the appropriate pathways is really, really important. So I think a multi-pronged approach is very, very important.
It's good to hear. And Christine, any thoughts on these multidisciplinary clinics?
I think they're incredibly valuable. I think the concept of having a clinic focused on AD may not be practically viable, but having a dermatology multidisciplinary clinic, and where there's a rheumatologist, nurse, counselor, allergist, that the whole group is together, or at least tightly knit, even if they're physically not in the same space, but that there's a real interconnection and a real web that's connected, so that they work together. I think that kind of approach is really great for patients.
And your views on multidisciplinary clinics, Paul?
I'm grappling with it really, because I think the practicality of it is hard, and I think probably really good for really difficult to manage patients. So if you sift out the ones that are the most difficult to manage, and then you put the input into those, then I think that's practical, because you have that in a unit somewhere for difficult to manage patients. But for most people, I don't see it being practical. Certainly in my experience in UK, you just couldn't make it work. But you could for the difficult to manage ones, who are going to be the most ones that are suffering most and are going to actually use the most healthcare resources. So looking at the Kaiser Permanente model, where you work downstream and cut the costs further up, you can probably make an economic argument as well as a clinical argument for that. So great idea, just I'm not quite sure how you make it stick really in reality.
Well, it does work in some countries.
Yeah.
Where they do have it.
Yeah, I'm sure.
Maybe a revised model where you don't have as many subspecialities, but certainly having, initially the doctor and the nurse working well together with regards to the patient education, and then if there were expressions or concerns around a patient's psychodermatological concerns, then you could make referrals into the appropriate specialists from there.
We did a study in Canada a number of years ago where we looked at using physician extenders like dermatology nurses, and some of the clinics were very, very effective in their use of dermatology nurses. The patient saw the dermatology nurse for 15-20 minutes, half an hour, saw the dermatologist for a brief period of time, and then followed up with another half hour with the dermatology nurse to go over the full treatment plan, and the patient felt well cared for, and the practice ticked along very well.
Yeah, I can see that with that model, but when you start adding in all these other people, it could get quite complicated and be quite difficult to manage.
But I think it's actually really important that we consider
Absolutely.
the mental health aspects of skin
Absolutely.
disease.
No.
And so I'd like to see that we marry these two together much more closely, dermatology and mental health, because most people living with skin diseases are
Absolutely.
grappling with self-esteem issues.
And it'd be really interesting
Agreed.
to see if there are any really good cost-effective models of multidisciplinary care, like the data does it back it up as
Absolutely.
well. Because if you have clinics that will do it one way, you know, and what's the evidence for it compared to another clinic that does it another way? So it's just interesting to compare them as well. So I'd like to move on to another topic now, and obviously we've heard the needs of patients. So patient groups are offering this extra support to patients and their families. So I just wanted to look a little bit now about what role exactly do these groups play, and also what are some of their challenges. So Holly, would you like to start us?
Yeah, I'd love to. So I believe that patient advocacy groups and organisations have a key role to play in supporting patients with atopic dermatitis. There's a big bridging the gap between the clinical services that patients are waiting for or have. There's a key role to play in educating patients to understand that atopic dermatitis is a lifelong condition. There currently isn't a cure for that, and it's about effective management of atopic dermatitis and improving quality of life, and how as a patient organisation we can do that. Signposting to resources, signposting to patient information. Patients need to understand what it is that they have and how they can best deal with that. So signposting to tools and resources is really important, and I'm sure Christine as well, you would agree with me here that raising awareness of the impact that these conditions have on people is a really important role for patient groups.
Absolutely.
And some of the challenges, Holly, that your groups face before we move on to Christine? I mean, are there any challenges?
I think it's a lack of access to specialist services for the more severe end of the spectrum, for the persistent and problematic atopic dermatitis, and getting people to understand, as we've touched on, that atopic dermatitis isn't just a skin condition. It goes far beneath the surface and impacts on lots of different areas.
Okay, Christine, please.
So I'm going to echo what Holly just said. I think the awareness the lack of awareness amongst policymakers, amongst the general public even, that these diseases have impact is a key role that patient organizations play. So and that patient support at the basal level, education, but also that voice at the end of the phone that says you're going to be okay, and that's key, and that's something that sometimes, I mean, your doctor can say it, but when you go to the doctor, you know the doctor's going to say that. But when somebody else who's living with it says it, I think it makes a huge difference.
Support and time are two things that the clinicians don't always have as
Exactly.
well. I'm sure you'll agree, Paul, in consultations you're often battling against the clock to do everything you need to do, and just that's where patient support groups can build a gap and give the time, listen, provide that support, which is really important.
Right.
And not just to patients, to the carers, like keeping in mind that this is a disease that affects young children and then on up, and the family, you know, it has a tremendous impact on family as well. And we're very proud to work with patient advocacy groups in atopic dermatitis. We learn a lot from patient advocacy groups, actually, and I think that they can be a source of really valuable information and support to not only patients, families, the physician community, but also companies like Pfizer who are trying to make a difference.
Right. So let's just go back to healthcare systems. So we know that, you know, primary care physicians don't have much time to spend with patients. Well, you know, they try to do the best they can. So how could policymakers address this, Paul? What do you think they could do?
Well, I was just thinking about policymakers and what really influences policymakers. And I have to say, it comes down to money mainly, in reality, because it's all about economics. So I think if you want to influence policymakers, you have to make a good economic case as well as a clinical case. And I think the lack of data makes it very hard often. It's all a bit fudgy. So I think, how can policymakers help? If you can make an economic case, then you can put the resources there first of all. So once you've got the resources, then you can allow patient groups and clinicians and patients to get together and decide how best to spend that money. If you haven't got the money, then you're stuck. because you can't. It's very hard to do it. You've got to find ways of using the little resources you have. And I think patient groups are a great thing. And in UK, I don't think they're used enough, and they're quite hard to access at times. And it'd be nice to have a much wider base of those and know how to access them.
Should they be put on prescription? You should
Well,
see this patient group.
Well,
that was
it would be
something
nice to have even a list of who they are and where they can be contacted, and with phone numbers that are in date, which often doesn't happen. And when you do have one, the person's gone away or it's become defunct. So I think, you know, there could be a lot of work done with pharma to help develop these groups, with government, and it's quite cheap actually. It's not an expensive thing to do, because a lot of these are going to be volunteers, so it's only a question of pulling it together.
Okay, actually, can I speak to that?
Yes, and I've got a question from our audience about the role of pharma, actually, which fits
Okay.
in nicely now, but please go ahead, Christine.
Yeah, so I have 2 points I'd like to make on that. So the challenges for patient organizations and for our members around the world, how do we keep ourselves alive? We're organizations, and yes, some are run by volunteers, and the problem is, though, if we look at atopic dermatitis, we're talking about parents or people grappling with the disease themselves.
Yeah.
And patient organizations run by people living with disease or in a family with a disease, they're already stressed.
Exactly.
And what my organization is working on is the professionalization, basically, of patient organizations, helping them to become more professional. But the thing we keep bashing against is we don't have the resources.
Yes.
So patient organizations need resources. So in some countries, governments give some funding towards patient organizations, which then bars them from working together with pharmaceutical companies as partners. In most countries, that's not the case. And then the only sources of funding that patient organizations have is really working together with pharma partners. And many/most, and certainly all of our members, we have a very hard line that we draw between us and pharma. We work together. We work together as long as our projects are aligned, but they don't influence what we say or do. And we have hard policies around that. And we need decision makers, policymakers to understand that we're acting as professionals, and that working together in partnership with pharmaceutical companies does not impact our impartiality. Our allegiance, an alliance, is to the patients, and patients first.
I think you've
Yeah.
answered the question in this from the panel, from outside in the audience. Well, thank you for that, Christine.
Okay.
I was looking at models of care. So we mentioned on teledermatology. There's also this concept of atopic schools that exist around the world, particularly in Germany, where patients are really go on a course for 6 days, learn everything. I mean, do you think that is a feasible way forward in some countries, especially the UK's NHS, which, you know, cost is a big factor? Love to hear your thoughts on atopic schools.
I think patient education systems or classes, not perhaps on the grandiose scale of 6 days, but certainly a morning workshop, an afternoon workshop, could be a really, really great way forward for patients to be empowered and to have the knowledge and information that they need to take good care of their skin, as Paul touched on earlier on. The adequate, appropriate use of emollients is the day-to-day treatment for atopic dermatitis. Many patients that I speak to don't understand how to put the creams on, what quantities to put it on. A lot of parents will have phobia around the use of corticosteroids. They'll be scared and frightened to use it because of perceptions over side effects. So it's really important that they're educated that actually these treatments are well researched and they're safe to use, as long as you're following the guidance. But if nobody's had the time to take to show them, then that's a really important area, and workshops or classrooms that specialise in eczema education could be one way of addressing these and freeing up clinicians for other areas.
Thank you for that.
I was going to say, I think they're great. I mean, I think there's things like there's back schools and pain management are things that are going on at the moment that work really well. But I think a lot of these, the problem is the idea is great, but it's keeping it going and getting people to come.
And getting it funded.
And getting it funded.
Yeah,
I mean, I'll give you a quick
resources.
example of this, is that I was involved in a healthcare organisation, and it was stop smoking clinics. And they had, the government policy was to put these in deprived areas. So in the deprived areas, people were not going to the stop smoking clinics. In the sort of not so deprived areas, it was overfull. So I suggested that we ought to put another clinic in the overfull area, but no, we weren't allowed to do that because it had to go into deprived areas. So they put another clinic into the deprived area where there was no one going.
Yes, there are quite a few challenges.
Sometimes government policies, because what happens is when people give you money, they try and be too prescriptive because they can't trust you to spend it properly. And yeah, I guess sometimes people don't spend it properly, but most times they do. And I think when people give money, they need to let the people who know what they're doing get on with it. And that's a problem that happens quite often. Governments interfere a little bit too much, but I can understand why they do.
Moving on a little bit
Can
now.
I ask, Andrew,
yes.
to the point that you made earlier, or the question that came earlier about use of technology, I think there's a really good potential use of technology here around setting up webinars that are instructional and that then can be shared over and over and over again, and then can be shared in remote areas that are instructive. And I know that some of our member organizations have this kind of information on their websites, as do you, right? So there is information out there. The question for patients is always which ones can they trust, which you know, who's trying to sell them something and who's not.
Yeah, and I think to Paul's point was, you know, you have to adapt the response to the community needs.
Absolutely.
And there'll be cultural differences, there'll be educational
Absolutely.
differences. And so, you know, policy is about trying to find the right mix of things. And so you do need experts like Christine as a patient association leader and nurses to be able to say, well, we don't, you know, that's probably not going to work in this case. It'll probably work really well here. And so that it has to be flexible so that you're you know, we're not monolithic, you know, and in terms of our needs and the way we access information. Technology is great. I use technology when I want to, you know, find out how I put oil in my lawnmower, you know, and all these very, very practical things. And so there is populations that will use it, but we have to be flexible in terms of what's going to work really in which community.
That's the key.
Yep.
And which age group too.
Yes.
So in our report, we looked at lifetime prevalence as well, and we found that across the world it ranged from 9% to as high as 32% in Australia. And so I just wanted to have a look at this prevalence. So the data indicates AD is on the rise. So what is driving this? Paul, do you have any thoughts on this?
Well, I've got a pet theory, but it's just my own feeling, is that we wash too much. And I think, you know, everyone has to use all these smelly things now in the shower and everything to make us clean, and we always wash with lots of soap. And quite honestly, if you get these patients not using soap, that makes a massive difference to quite a few patients. They stop itching because they stop scrubbing their skin with soap, which of course takes all the grease and destroys the skin barrier and creates the eczema. So my pet theory is stop washing as much. And I tell people just to wash with water, and they look at you as if you're mad. They say, what, wash with water? And I say, yeah, you don't need to use soap. I never use soap, I say, and they look at me. So I think if you can encourage them to use emollients to wash with soap substitutes, get them to understand that. You get things like barmaid's hand, where people are washing their hands all the time. Get them to use emollients and soap substitutes. That's all you need to do.
Thank you
often.
for that. Any other thoughts from the panel?
Well, I think we've known for a long time that atopic disease runs in families, and that there's a genetic and a hereditary element to that. And when we talk about atopy, we talk about an umbrella of allergic terms, so allergic rhinitis, we talk about allergic asthma, food allergy, and atopic dermatitis. And commonly atopic dermatitis prevents in childhood, in infancy, and some children will outgrow it and often they won't, and it will persist into adolescence and older years. So it's looking at what we already know about genetics, but also what we're doing with regards to modern lifestyle and the way lifestyle has changed, how very clean we are now, and the types of things we're feeding our children, the type of environment we're living in. I think there's lots of threads there, and whilst we know a lot, there's still key pieces of the jigsaw missing.
Yeah, I think, and that's a key point. I think this is where it's really great that there is a focus on atopic dermatitis and on skin diseases in general. That people are now beginning to take these diseases seriously, and we've got more research happening, and I think that is going to give us more information about why the prevalence is increasing.
Yeah, it'd be good to find out all the gaps. And so looking at now how policymakers may be able to respond to this burden on family members and caregivers, because they're often forgotten. So what could they do, policymakers in this field? Any ideas, anyone? I mean, they're often forgotten, that all the work they do in the background scenes?
They absolutely are, and I think that goes well beyond our conversation about atopic dermatitis, it goes to caregivers of anyone with a chronic disease, outside of dermatology even, and I think policymakers and politicians. I think if those people got together and started speaking and started having a voice, then I think politicians would find that if they developed policies that would support caregivers, they would get elected much more quickly.
Well, they may do, but I think one of the issues with this caregiving thing is, unfortunately, there's an awful lot of people who use the system to their advantage, and I think that scares policymakers, because if you start giving benefits to people who give care, that's great, and everyone says that's a fantastic idea, we should do it, and who wouldn't say there's an economic argument and a social argument for doing so. The problem is that politicians and other bureaucratic people have got a mistrust. And I think that's the problem, is who's going to actually milk the system, and unfortunately there's plenty of evidence that people do. And that's a scare of it. But it's a shame because,
But on the other hand, I mean, it doesn't have to go necessarily down that. I think one of the things that policymakers could, would be helpful, we can help them better understand the cost of the disease. And so being able to not only look at, what is the cost of the treatment, but what is the cost of lost productivity? What is the impact on the mother or the father that has to take time off, because they can't hold down a full-time job, because that is full-time. So I think part of the policy response is trying to figure out, are we really understanding the full cost of this disease?
Absolutely.
Or are we just, narrowing it to a certain perspective? And I think in that case, if we started there, then we could say, well, maybe we need a little bit more resource here, maybe we need a little bit more resource here.
And I think, to be fair, I think policymakers are beginning to look at this. Yeah. I think it is happening.
Yes. Oh, yes.
And I think some countries have policies in place or are working on them, and so I think.
It's a trend.
I think it's trending, exactly.
Fantastic. So we touched on this concept of comorbidity. So I just want to fully explore this now. So what are some of these comorbidities associated with AD? We've looked at the atopic, but are there any other conditions that are linked to AD that are causative or not?
I think a key one for me, and sorry to jump back in and kind of hog the limelight there, is the fact that early onset eczema or atopic dermatitis in infants under the age of 3 months or roundabouts is a significant risk for the development of food allergy, and this goes into our understanding of atopic dermatitis as a disease and the prevalence in food allergy. And there's definitely links there. So where the skin barrier becomes broken, then environmental allergens and food allergens can be shown to the immune system, and sensitization can occur. So if we can get right the prevention or the treatment of eczema earlier on, then we can hopefully make an impact on those children that do or don't go on and influence their allergic journey. So I think that's a really important point for policymakers to understand.
What about mental health, Christine?
So is the chicken, is it the egg, right? Do people with visible skin conditions have mental health issues because of the stigma, or is it something that is part of the inflammatory cycle in the skin conditions? I don't know, but it certainly plays a large part in AD, in atopic dermatitis, and it's underdiagnosed, and people themselves. So the minimization happens not just in the public, but it happens amongst patients themselves, and they say, I should be okay, even though I have this, or we should be okay as a family because it's just a skin disease. It could be so much worse. And so that minimization takes away the validity of the way that you feel, and that results ultimately in some sort of mental health stressors.
Paul, any thoughts on this?
Sort of my GB hat on. Virtually every other patient comes in with some sort of mental health issue these days. But there's definitely, with chronic disease, there's definitely a link. As you say, whether it's chicken and egg, whether people become anxious and then that causes a flare-up of their chronic disease or whether the chronic disease makes them anxious, I really don't know. And there's probably a bit of both. Unfortunately, many people are not learning coping skills for anything nowadays. If you sit in the GP surgery, one of the reasons GPs can't cope with their workload is because people can't cope with anything now. They've then lost the ability to cope. And that, I don't know what it is. Lost, you might say, might be breakdown of communities, not good parenting, I don't know. But that's my observation, being quite an old codger now in general practice, having done it for a long time, that people just don't cope. And I think part of it is people move away and they don't have any support. But they don't cope with life. People just don't cope, and this is just another thing they can't cope with. So.
Well, thank you for that. I wouldn't say not very optimistic notes, but
no.
Sylvia, did you want to add anything at all?
Well, I think, we've had an opportunity to talk to a few patients, and I'm not an expert by any stretch of the imagination, but I think as Christine mentioned, the impact of stigma is very, very high for especially young people. And I've had occasions where I had a young girl come and wouldn't go out in the evening, and so there's limitations. And I think if you feel overwhelmed, if you don't understand what's happening, if you feel like you can't control this or you will never control this, then that is loss of hope. And it's not imagined, and it's very real. And so I think the more that we can help them understand the disease, the ways of managing, providing some support through different groups, but also looking at different ways of managing the disease and trying to assess the severity and so forth. So I think every individual is different, but as you said, across skin diseases, it's a common thing, and it's not surprising because it's something that you see.
Yeah.
Yeah.
Can I just add one more thing about
Got
the
little time
inflammatory,
now.
the inflammatory nature of the disease? So I've attended a number of conferences now, medical conferences on atopic dermatitis, and there's research that's underway now that shows that beyond the allergic comorbidities, they are now looking at and investigating other comorbidities that they are seeing show up. And I don't want to, I don't know, I can't recall which of those have been proven, or whether they're associations or actual, if it's actually been shown that it is a comorbidity. But I think because we're looking at a systemic inflammatory chronic condition, other organs are being affected, and it's just a matter of time before we nail down which ones.
Well, thank you. That was fantastic. Thank you so much. I learnt a lot. I hope you all did out there. I'm just going to ask our panel now for their final concluding remarks. You can either comment on an area for research or a take-home message for policymakers around skin diseases or AD. So just very briefly, your last concluding comments. We'll start with you, Holly.
Thank you. I would like policymakers to look at ways that we can get the robust evidence and to help get some research that we can make guidelines and have policies on to support clinicians in practice. I think that will make a real difference to patients.
And I guess my take-home message is that when we're looking at people with skin diseases, that we need to take the whole person into consideration. It's not just what's showing up on the skin. Skin diseases are actually much more than skin deep.
Fabulous.
I would say you need to create the economic argument to allow the resources for physicians and other clinicians to treat the patients properly, empower the patients, and there's hope. And the hope is that you need to give people hope that you can do something about this condition, you can manage it. You may not be able to cure it, but you can manage it successfully in most cases.
And I would agree with Paul. I think policymakers do need an economic argument, and I think generating that economic argument starts with measuring the issue, and so you can't manage what you don't measure, and I think prevalence data is really important to gather, as is the full cost of the disease.
Fantastic. Well, a big thank you to our panelists, to our sponsors, Pfizer and Global Skin, and to you watching. This webinar will also appear as a recording on this website later today. Thank you very much.